And so there has been a lot of models over this last year. This was one in Lancet that just looked at HIV deaths. And, you know, if you look at the impact on HIV deaths, if you cut PEPFAR completely, then there'll be this massive increase in HIV deaths. And then here's the models if you just cut it, you know, somewhat. And remember, other fields besides us are worrying about this, like family planning and maternal child health and TB. We're focusing on HIV, but there's a lot of outcomes that is being modeled for other fields. And then finally, the South Africa problem is a very big problem because we learned at the CFAR meeting at CROI that it was a bot. It was AI, because AI sucks. Like Grok is Elon Musk's AI, and Grok hallucinated that South Africa was genociding white farmers, and that K went out, and then Trump knows it wasn't true, but anyway, he put a freeze on South Africa aid, and that was on February 7th. So there's a specifically executive order on February 7th that freezes all foreign assistance to South Africa because of all these different reasons. And unfortunately, the NIH has interpreted that as no new research in South Africa. And I verified even as this morning, we thought we could go through global programs. It's not going to happen. There can be no new research in South Africa during this administration unless this executive order turns around. So it's a disaster. But anyway, so what about specifically on South Africa? What's the modeling of discontinuing PEPFAR support? Well, all these models have been very concerning because, you know, so much of PEPFAR we didn't really realize until Chris Bayer told us this last year at CROI, just a month or so after the administration started, how much PEPFAR was supporting prevention in different countries, including South Africa. And so the models are really concerning about new HIV infections, even if the countries, which they absolutely have done, have taken over their own ART response. So ministries of health are giving out ART to their populations. They're not going to let people with HIV not have treatment, but prevention's like a luxury. So then what has been happening since? Because it is a lot less dire this year than it was last year, because the Global Fund was still there. It's like somehow they'd forgotten about the Global Fund and they weren't going after the Global Fund like they went after USAID or PEPFAR. And so actually the Global Fund, the goal was 18 billion, and at least it did achieve 11.34 billion. Gates put in my opinion, a drop in the bucket, given that he's in those files. And then UK put good some, Germany, but the US did put in $4.6 billion. So that's helpful. Like there was, you know, replenishment of the Global Fund, and that's very helpful in terms of AIDS deaths and acquisition of HIV to have the persistence of the Global Fund. Definitely not where it was, but still, it looks like the next 2 years, we're going to at least have that as a modality. And then in terms of PEPFAR funding, PEPFAR authorization did expire March 2025. By the way, that was a consequence of the former administration. They had not reauthorized PEPFAR for 5 years. That could have saved us a lot of trouble, but they did not. They only authorized it for 1 year. But it's still part of US law, and it can be funded by continuing resolution with funding appropriated by Congress. So Congress in January 20th did us a lot of favors. I think it got maybe eclipsed by Minnesota and then by this new, what attacking other countries. But actually, the HHS budget by Congress on January 20th was great. It kept the NIH budget totally intact and actually increased it by 418 million. And importantly, PEPFAR did get ongoing funding, 2.9 billion. It is less, but there was ongoing funding. Jeremy Levin is one of the young men who are associated with Elon Musk, who was part of Doge. And Jeremy Levin seems to have a lot of power for PEPFAR. And he said 35% is spent on frontline costs. That means commodities, which is about 20%, then all the frontline healthcare workers, which is like another 10 to 25%. The rest is technical assistance and NG overhead and stuff like that, right? And so he said that in the PEPFAR press briefing, so you can clearly see that we don't have the longstanding expertise of the PEPFAR, the people who used to really help us with PEPFAR in the State Department, and we have people who don't have that same experience running these programs. And then in that budget that the Congress put out, America First Global Health Strategy does maintain 100% of frontline support, but they're giving the money directly to countries. And that could seem like a good thing, but actually it really depends on the country and the America support and the America part of PEPFAR and what they'd established. It would have been really helpful to have that $50 billion not just go directly to countries. That wasn't the entire... you want to phase out and get to in-country taking on their own responses. So that's the complaint that's made about the $50 billion that was appropriated in Congress in the HHS bill on January 20th. So where are we? I will say, and this was, I think, a really important thing to say, I know we all love prevention. We want prevention. But if we could treat everyone in the world, that would really contribute to HIV decline. So I think that the fact that the countries are putting their own dollars and responses into HIV treatment, I think is really appropriate, because we really want that undetectable equals untransmittable. And I think that's a very appropriate response of countries while we're figuring out prevention. So this session was really good. It was Monday afternoon, and I think the conclusion is that changes in HIV funding has been a shock to the system, but really it's been better than we thought. This time last year, I think we were much more worried, and things have seemed to not be as shocking or as taking it all away at once than it seemed. And I really I really like the Global Fund, and governments are being given control, but I think it's really important that the US still has a presence as this transition occurs. And then we do need to maintain HIV treatment. If I was going to really put number one, if I had to do anything with the dollars, I think that's the right thing. And condoms, by the way, are a preventative modality. And then also do our donor priorities match country priorities. So I would encourage you to watch this session. Okay, let's go on to, I said some of this right now in HIV Grand Rounds, but I just will mention a couple of treatment studies, but I really want to focus on prevention since we just did treatment, but not everyone on the CFAR seminar was in our HIV Grand Rounds. So if we really think about treatment, I just really want to recall that 2026 is the 30th anniversary of 1996, and it just is a very big deal to be in the 30th year of ART, I think, this year. And so many advances along the way, including long-acting starting in 2021. And we always needed 3 drugs. And now, if you get really powerful drugs, maybe we'll need 2 drugs. So we are, as of 2013, we've been in the integrase inhibitor era in this country, meaning we were with raltegravir. It was awesome from 2008, but it was really when dolutegravir came out and a lot of other studies that first line became INSTIs in this country and worldwide. TLD was put on the WHO guidelines in 2018. So we're in the INSTI era. But there were lovely talks at CROI about the capsid inhibitor. And I wouldn't just point to Dr. Sundquist's lecture from the University of Utah in the plenary, but if anyone got a chance to go to the Scott Hammer presentations on the first day, I thought Dr. Neil Stone's presentation from Royal College London was really nice on the capsid inhibitor, and just how, because it works on multiple steps in the viral life cycle, it just seems like it's going to be really, really very strong in terms of its genetic barrier resistance. And also, there seems to be a cleavage occur, there's a very, and Steve and Peter can explain it better than me, but it really just does seem that it has a high genetic barrier because of how it fits into the pocket. So if we're in the era of the capsid inhibitor and we were already in the era of INSTIs, then the study that I want to point out to you is the study on bictegravir lenacapavir. I will point out that SPLASH, the Ward 86 long-acting program, did present the biggest case series of individuals on lenacapavir cabotegravir. It was actually 46 people on lenacapavir cabotegravir with or without rilpivirine, and almost 100% virologic suppression rate. There's something really powerful about that capsid inhibitor and an INSTI. And Steve, yesterday we got news about our R01 and Splash, so I think that's going to be incredibly interesting if we look at the reservoir. So I went over this in HEB Grand Rounds, but it's not the same audience. I will mention the two Artistry 1 and 2 studies, which were presented at CROI. Artistry 1 is switching over from really complex regimens that people were on to Biclen. It's one pill. And Artistry 2 is switching over from Big TAF FTC, which the same drug company makes, to Biclen. And the data from both these phase 3 studies were presented at CROI 2026. Now, Artistry 1 was presented by Chloe Orkin, and it was a nice study in that people were older, like the median age was actually 60. They had an average of being on 28 years of HIV therapy, and they had a lot of resistance because you've accumulated a lot of resistance by the time you get to 28 years of therapy. And so, and 78% were on boosted PIs. So maybe people hadn't been looking at their regimen and trying to simplify that, but at any rate, they got randomized into either staying on that regimen or going to Biclen. And Biclen as a single pill combination, which is much easier than taking, multi-drug regimens, was non-inferior to the complex regimen. And Biclen did improve cholesterol, mostly because you're taking them off PIs. And so boosted PIs. So that was nice for Biclen, though a question came up, couldn't we switch them to Big TAF FTC? And then everyone debated, well, I don't like tenofovir in my older patients all the time. And then the Artistry 2 study is switching over from Big TAF FTC to Biclen, single pill, and also a non-inferior outcome. So maybe if you don't want them on TAF because of bones or kidney, then you can switch over to Biclen, but remember, it doesn't have hepatitis B activity. And one participant did evolve at R263K. Okay, and then I will say, and I don't want to take into the other people's time, so I'm going to actually go fast, is that islatravir and lenacapavir is going to be an interesting once a week combination. And anyone who does implementation science in the room, I think it's going to be very interesting to think of the interventions that would help people take a once a week regimen as opposed to a daily regimen or long-acting ART. And there's some people who don't like needles. Maybe 14% of our participants in our SPLASH program discontinued because they don't like Cablen as needles. So it's Rilpivirine as needles. So maybe they'll like once a week. But this is only the phase 2 data. We're going to have to get the phase 3 data. And then there were a lot of drugs in the pipeline that are brand new that I'm not going to go over. Okay, HIV prevention. The one big message on HIV prevention is that Purpose 1 is that lenacapavir study in cisgender women that has over 2,000 women on lenacapavir, presented first in Munich, Germany by Linda Gill Becker, and everyone stood up. It was exciting. It was published in the New England Journal that same day in July in 2024. This is the follow-up of Purpose 1. So, what happened in the open label extension. And then Purpose 2 is that same study, but in men and in gender diverse individuals, and also 2,180 people on lenacapavir. So you're putting together more than 4,000 people on lenacapavir and looking at the open label extension phases of Purpose 1 and Purpose 2. And to make a long story short, in over 4,000 individuals on lenacapavir, still really good protection, really high levels of protection, and there are 5 incident HIV infections out of those over 4,000. And if you look at those 5 HIV incident infections, they are listed here, and 4 out of 5 of them did develop lenacapavir capsid mutations. We don't know about non-canonical mutations, that's a whole other topic, but they presented with, they did get lenacapavir mutations. So 5, 1 couldn't be sequenced, and there were resistance mutations if you broke through. And it looks like N74D is one mutation to think about. And then MK8527, which is an NRTTI, we don't have any data on this. We just know the dose now after CROI 2026. MK8527 is going to be a once a month pill studied for prevention in men and women in two studies called Expression 10 and 11, respectively. But MK8527, what's that dose once a month? And just with a lot of modeling, it's coming out as 11 milligrams. So that's going to be the final dose that looks like is going to go forth in the trials. And then lots of commentary on hepatitis B, because when we talk about hepatitis B prevalence worldwide and the fact that every regimen we're just talking about doesn't have tenofovir in it, they all don't have activity against hepatitis B. The new long-acting ART regimens, the new Biclen, islatravir, doravirine, they don't have activity against hepatitis B. And I would point out that we had a LEAP meeting, which is led by Charlie Flexner at Johns Hopkins on the Sunday before the meeting started, Saturday. And I think everyone kind of came up with a consensus thing about what to do with hepatitis B, that you screen for antibodies, surface antigen. If your surface antigen's negative, go forth, use it with impunity. Don't worry about it, but definitely vaccinate if you're not hepatitis B surface antigen positive. And if you're hepatitis B surface antigen positive, you can still use these long-acting, people think, but just keep on checking without positivity. Sorry, core antibody, but without positivity. Keep on checking surface antigen every 6 months because you don't have protection against hepatitis B. And then the final thing to end with was a abstract that got a huge amount of attention, as it should, which is the SURGE study. This is we all know the SURGE study led by Diane Havler here. Really incredible work in multiple ways, but the specific question here was a community precision health intervention on HIV testing, where they've always been looking at different ways to deliver treatment, different ways to deliver prevention with long-acting and oral and covering everyone that way. But the question in this particular abstract that was presented at CROI in an oral session is in 16 pair-matched communities, 8 in Kenya and 8 in Uganda, looking at essentially over 42,000 participants in each setting. What did we do in terms of reducing HIV incidence? What did the study show in terms of reducing HIV incidence? And essentially what this study did, and people got testing in all sorts of platforms, because that is the beauty of SURGE. They're very community-based. And people have choice about where they can get tested and also get where their interventions, that there was a 70% reduction in HIV incidence in intervention communities. So of all the infections that were identified, really the majority of them were in kind of the standard of care communities and in this cluster randomized controlled trial in the intervention communities with all these interventions and all these ways of testing, really, and everything else that was happening, prevention and treatment, a massive reduction in HIV incidence. So very exciting data, and I'm going to turn to Peter now to do comorbidities. Thank you.
Thanks, Monica. And I'm gonna go pretty quickly. First, a shout out to Steve Deeks for his carefully curated cure slides that helped. I'm going to start with comorbidities. The first thing that caught my eye was this randomized controlled trial of valganciclovir in sub-Saharan Africa among infants with HIV. Turns out that CMV pneumonia, unbeknownst to me, turns out to be one of the leading causes of death among infants born with HIV in sub-Saharan Africa by recent autopsy studies. And so the empirical trial randomized people. It was a factorial design trial. They also looked at TB treatment, empiric TB treatment, but this really focuses on the CMV treatment part. They found a significant 40% reduction in mortality, infant mortality, at just 2 weeks of therapy, and that held a significant reduction in mortality held at 30 days, 29% reduction, including deaths that occurred after hospital discharge. So up to 2 weeks after they stop treatment. And so treating CMV in infants seems to have this profound effect. And that's very different than what we see in adults. The infant immune system is very immunoregulatory, and CMV is likely, and infants are much more susceptible to CMV. So that's an important study. Also from sub-Saharan Africa, an increasing focus on heart failure and its diastolic dysfunction that we see preferentially increased in people with HIV. And so this is a study from Cape Town identifying an increase over like 1,000 people with HIV, 500 people without HIV, large echo study, showing increased diastolic dysfunction. And interestingly, it was greater in women than men. So the effect of HIV on increasing heart failure was particularly seen in women, not so much in men. So an important sex interaction. And Rebecca Abelman here has been studying, the impact of HIV on sex differences in inflammation, which are pretty striking, particularly at the menopausal transition. So we wonder whether that may contribute to some of these preferential increases in heart failure among women and men. We heard more from the Reprieve group about statins. This is already known in the general population. Wasn't known to me before CROI, but others in the general population know this, that statins slightly reduce blood pressure as well as lowering LDL cholesterol. This was seen also in the Reprieve trial. A modest decrease in blood pressure. So that's good. Although, as a reminder, Reprieve did not reduce any of the comorbidities that are the leading causes of death among people with HIV global, including TB, infection-related cancers, and the like. So we still need interventions for those, as well as for heart failure. Statins didn't reduce heart failure either. And so more from the CERT study. This is focused on the increased focus on obesity in people with HIV, weight gain during early antiretroviral therapy that a lot of us clinicians have been concerned about. The CERT study did a really nice job of comparing this to the general population in East Africa. And what they found is that while there have been recent increases in obesity in this setting, the increases are actually greater among people without HIV than with HIV during the era where we're switching to dolutegravir-based regimens. So that's important to note. That I think we've been observing this weight gain, but we need to keep in mind that it may not be actually it may actually be greater in the general population than it is in people with HIV. Another thing that's really important, I think, and I'm glad to see that this getting more attention at CROI, is infection-related cancers. And this is a really nice study from NA Accord showing a dramatic increase in oropharyngeal cancer over the last 20 years or so. It's gone up threefold. The incidence rate has gone up threefold over the last 2 decades. Something I want to point out here, it wasn't really highlighted in the talk, but I think may be important, is that there appeared to be starting to be a decline in the mid-2010s, but then it just around 2015 really started picking up again. That wasn't highlighted in the talk, but I think there may be a biologic reason for that as we've switched from some older ARV regimens. And I'll come back to that toward the end as to why I think that may be worth looking at. And of note, these cancers are much higher in heterosexual men and in those with low nadir CD4 counts. It turns out that oral transmission of HPV is much more efficient through vaginal oral sex than oral sex with men. There are some other important presentations in the TB arena among people with advanced HIV. Mortality rates are incredibly high. among people with low CD4 counts presenting with TB. And so a variety of approaches have been tested. One is just treatment intensification, give more drugs, higher doses. Didn't seem to make any difference in this study. And yet another study looked at adjunctive prednisone to decrease inflammation. And that also made no difference. And in fact, this was a factorial design trial that also looked at TB treatment intensification. And the trial was actually stopped early because the people who got intensified TB treatment actually had increased mortality. So giving more drugs does not necessarily help the situation. So we're still in a really difficult situation with TB in people with advanced HIV. And ideally, we need interventions that prevent TB in the first place. I'm going to shift to cure now. Thanks again in advance to Steve for his curated slides. I saw him working on these on the airplane on the way back from Denver. The first theme that came up in the cure field is this idea that if the immune system gets a little bit of experience with the virus during an initial treatment interruption, and then you re-challenge with another interruption later, you do a better job of controlling the virus after the immune system gets educated, if you will. And what the Rio trial did was, and they had studied BNAbs to see whether they might induce post-treatment control. And last year's CROI, we heard from them that there was an increased number of people who were able to control the virus during an ATI who got BNAbs. And but the placebo arm was allowed to undergo to go into the active arm after the first phase of the study, and then undergo a second ATI. And in that group, the proportion of people the people had a delayed rebound and also lower viral load set point and the like when they during the second ATI than people experienced in the first, suggesting that the immune system was learning somehow from that first treatment interruption. And this brings back some old studies from like Bruce Walker's group. It's got to be like 15 years ago now that showed that sequential ATIs can induce increased levels of control in people who start ART at very early stages. So a similar theme comes up in the non-human primate models from Mirko Pieridini's group, where he looked at a combination immunotherapy regimen combining anti-IL-10. IL-10 is an immunoregulatory cytokine that suppresses immune activation. So if you block it, you take the foot off the brakes of the immune response. And then anti-PD-1, which most of you know, these checkpoint inhibitors for cancer, both of those were combined, really potent blockade of these immunoregulatory brakes. And during the second ATI, after you get a second round of treatment, you see an even more exaggerated benefit. This is almost certainly not going in people because this causes a lot of inflammatory complications. But it's proof of principle that, again, educating the immune system with an ATI initially, and then coming back with an immune-based therapy may improve your chances at getting sustained control. Here's another one of those studies that probably shouldn't have been done, and maybe we probably shouldn't do any more of these anti-PD-1 trials in people. This is with HIV. This is my personal opinion, but this study looked at anti-PD-1 in combination with an alpha-4 beta-7 inhibitor to see if it would induce better post-treatment control. While it looked like the anti-PD-1 group, that's the budogalimab group, seemed to induce more control than placebo. What was the cost of this? In the poster, there were a number of inflammatory complications in this study, including diabetic ketoacidosis, type 1 diabetes. So, the participant in this study is going to be on insulin for the rest of their life. And so that's a major complication. And I think that these approaches, even though, reduced doses of anti-PD-1 that are used in cancer are being proposed, I think this is unlikely to be a safe approach for people with HIV who are otherwise doing well on ART. Joe Aaron came to the microphone at the end of the session and made that point pretty strongly to the group, which I agree with. Another theme at the meeting that's really spurred on by work that Rachel Rudishauser has done here at UCSF, really identifying the proliferative capacity of CD8 T cells as an important feature of cells to control the virus. Gaurav Gaya at Boston has identified in these so-called exceptional controllers, people who not only suppress HIV to undetectable levels, but also just reduce the reservoir to nearly undetectable levels. They have a particular NK like CD8 T cell phenotype in addition to that proliferative capacity, which seems to be really important. So that's another interesting feature. There was an important presentation from Lily Cohn and in collaboration with the SCOPE team, who did probably one of the most rigorous, probably the most rigorous ATI study ever conducted, where they followed people weekly after treatment interruption, including people who were viremic controllers prior to initiating ART, who they expected would exhibit delayed rebound and maybe better control after stopping. And in fact, those controllers had lower GAG copies per million CD4 T cells pre-ATI, so a lower reservoir. But when they looked at the immune responses, the controllers, interestingly, at what they call distal and proximal time points, these are time points before rebound occurs during the early ATI, when not much looks like it's happening in the peripheral blood. The immune system is sensing the virus in the people who go on to control. So a lot is happening here in multiple compartments of the immune surveillance, whereas in the people who don't go on to control, nothing. You don't see anything until the virus rebounds, and then all of a sudden the immune system wakes up. But the immune system is sensing, and people who are going to be able to control, the immune system is sensing the virus and able to contain it. And so that's an important observation. The next one also came from the UCSF AMFAR trial from Julia Wagner and Rachel Rudishauser's lab, looking at the period during early ATI, during BNAB coverage during that study, and found increases compared to pre-ATI time points in multiple immune activation markers. They also showed increased dendritic cell activation. Again, the immune system is sensing the virus during this early rebound period during BNAB suppression. So undetectable viral load in the blood, but the immune system is starting to sense the virus more. And that's probably a good thing, that it's probably contributing to the ability to subsequently control. But it also means that the BNABs are probably also not completely suppressive either, and that they are inducing a little bit of inflammation, more so than ART. That's important to know too. There was a lot on better latency reversal agents. IL-15 agonists are all the rage. They not only induce latency reversal from cells, they also expand CD8 T cells and NK cell responses. And so The Gilead group here has engineered a specific IL-15 agonist that only attacks the CD4, attached to the CD4 T cells to get rid of the CD8 and NK cell responses that may have been causing a lot of toxicities and inflammation, and just focus on the latency reversal properties. And when they do that, they see really potent reversal of latency in a non-human primate model here, better than you see with a TLR agonist. And what they showed is that you could actually reduce the intact reservoir with that approach. And then lastly, I'm just going to mention the TAC molecules, which I think are it's the story that went under the radar a bit at this year's CROI, but I think it's probably going to end up being one of the most important stories in the future. Liang Shan described this in a science paper several years ago, but some NNRTIs, in particular efavirenz, bind the GAG-PAL polyprotein, post-translation, prematurely activating the viral protease while it's still inside the cell. Normally, HIV escapes this by activating the protease once it's left the cell. But when it's active inside the expressing cell, it activates CARD8, which is an innate sensor that will induce pyroptotic cell death. And so this is a way of killing the HIV expressing cells without even any immune recognition. You don't have to wait for enough virus to be expressed for the immune system to see it. That can cause a lot of inflammation. This is a way of eliminating cells earlier. And Priya Pal from WashU St. Louis presented a poster of just 7 people who they gave efavirenz. They added efavirenz to an existing regimen, and they saw a significant reduction in cell-associated RNA, in a trend towards a reduction in infectious virus by IUPM, and also a reduction in the intact reservoir, but not the 5' defective reservoir, all consistent with this elimination of virus-expressing cells, which I think is very exciting, and not just because of the viral reservoir effects, which are modest, but if it's doing this, it may have effects on immune activation markers, and I think that's something that I'm really excited to see about. Whether this might be an effective anti-inflammatory strategy in the future. So, I told you I'd come back to why the oropharyngeal cancer seemed to pop up during the mid-2010s. That also happens to be the time when we moved away from efavirenz-based regimens to INSTI-based regimens. And I wonder whether there may be something here. So that's something to keep an eye on in the future. Monica already mentioned the great talk by Wes Sundquist on the capsid. Everyone's going to remember the soccer ball. I encourage you to look at the talk if you haven't to learn all this cool science about how capsid works. And then there was also a great plenary on GLP-1 agonist by Todd Brown. I encourage you to take a look at if you're interested in those agents. And now I'll turn it over to Mallory. Sorry, I know we're running late.
All right, thank you, Peter. I will go quick, A, because we're out of time, and B, because there was less content in social behavioral and implementation science at this conference. I will say that I've been impressed with the increases over time, over the years, in terms of the content for these areas, and I think it's going to continue to grow, especially as we're learning about newer prevention and treatment modalities that really are going to have impact and implications for how they're administered, the challenges and opportunities there. Batteries are running low here. Why not? Okay. All right. Why is this not letting me advance? What are we using to advance? I did. I broke it all.
Maybe it's tired.
Monica and Peter wore it out. Okay, there we go. So I'm just going to give a few examples of some of the more social behavioral presentations that way. There by no means is this comprehensive. So Kathy Sikkema at Columbia gave the results of a coping intervention on viral load among South African women with HIV and sexual trauma. And these were women who were either initiating ART for the first time or were reinitiating after a period of non-use. And so they compared an experimental coping focused intervention with a control intervention, an active intervention, a problem-solving intervention. And their goal, because everyone was initiating, they started them when they were already virally suppressed. As you can see in the blue line there, the active intervention that they were experimenting had a higher level of virologic suppression at 12 months compared to the control intervention. Going to keep moving on, sticking with South Africa, sticking with women in South Africa. There was a randomized controlled trial of dynamic choice of ways to receive oral PrEP for postpartum women in South Africa. And these are women who had previously been on PrEP, but it had been non-adherent or discontinued PrEP following delivery. And so they gave them choices on how to get their PrEP. Either they could get it delivered to their home, they could have this expedited, sort of streamlined clinic pickup, and then a couple of other options. And it really just showed that giving women this choice and allowing them to switch. So it wasn't just a one-time choice. They could switch how they got their PrEP, really improved at least their self-reported adherence. They didn't find differences in the urine tenofovir levels, but those are, as we know, those are short-term. So moving to men in the US, Adam Carrico presented results of an app of trying to reduce virologic rebound among men with HIV who use stimulants. And they have a smartphone app that includes positive psychological intervention skills. And so those are things like
the OPV and HPV. Oral, yeah,
yeah. I mean, I think
because
I think
we vaccinate women and not men.
Yeah. I think almost certainly that is HPV related cancers, particularly given the demographic risk factors. Strongly suggests that it's HPV related. They didn't have that granular data for NA Accord, but it's almost certainly HPV related. So,
and this is
I'm gonna steal my time back, and I'm gonna go. I'm gonna go from memory. Okay. So what I think I have in my slides. Okay. So a few other things I wanted to highlight. There was Aima Ahonkai, who is currently at Harvard, was at Vanderbilt, and is currently a visiting professor at UCSF. She presented a poster on her work training barbers in Memphis and Nashville that predominantly serve African-American men, a stigma reduction intervention, really going, I think there were like 40 or so barbers that she trained to really train them up to address HIV stigma among their clients, and both in person as well as their online social media presence. Another example of a poster, I forget who it was, but there was a poster looking at provision of PrEP within US-based substance use treatment facilities. And while there was an increase over the last few years, it was a modest increase of facilities that were actually facilitating and prescribing PrEP, went from 6% to just over 10%. So improvements there, but a lot of more opportunity yet to be tapped. Oh, look, there's some, is that showing on them or no? This is just me. Oh, yeah. That's all right.
We can send this.
I was very impressed with the content on both oral sessions as well as posters for transgender women in the broader category of gender diverse individuals. I think there's the TWIST study that Steph Barral presented. We done more cross-sectional, really looking at some of the, I need to cheat here, really looking at one of the findings that was particularly interesting was looking at social exclusion and violence and harassment and lifetime prevalence of that among transgender women. And that was, as can be expected, highest among transgender women with HIV, but still quite high among the whole population that they sampled. Asa Radix also gave an update on clinical consideration, clinical management for trans populations with and without HIV. That was well received. Then Sari Reisner talked about the Encore study, which is a longitudinal cohort study of trans women in the U.S. and Puerto Rico. And there was a lot, they're doing a lot with that. They've been following for, I think, 24 months, and I think they've gotten extended to 48 months recently. So they're continuing that work. And among some, I'll just highlight at least a couple of the findings. So not surprising, HIV incidence is continuing among trans women, in particular with higher rates. Oh, are we there? Oh, look at that. Higher rates among African-American trans women, followed by Latina trans women. Not a surprise. Let's see. And then, still connecting. Then looking at what were some of the predictors of seroconversion in this cohort, and they included unmet housing needs. Keep going. Let's see. Oh, I'll keep going. Made me think on my toes. Okay. Engaging in sex work and poverty, as well as being publicly insured or uninsured. Then in any stimulant use. So these are not surprising predictors, but they're persisting seroconversion among trans women in the U.S. And this was a sobering modeling study of what would happen if Ryan White funding ends in terms of, and this was in 30 states. It's a simulation study, and there were certainly some limitations to this. It was based on some surveys to different agencies. But what they concluded was that approximately there'd be a 73% increase in HIV infections if Ryan White funding were removed, and then a lower one if it were temporarily disrupted. And they broke it down by states as well. So not a very cheerful, but an important reminder of the importance there. And then I want to thank Matt Spinelli, who provided some overview of the implementation science themes that he saw. He wasn't able to be here to present, so I will butcher his slides for him. So I'll just quickly say what the three themes rather, that he identified. Why am I still holding this? Do I need this?
That's your voice.
That's still my voice. Okay. So one of them was testing, prevention, and treatment interventions that bring services home to home and communities were highly effective. As technology improved, self-collected HIV viral loads, as well as drug level testing are improving, and a lot on pharmacy prep and mototaxi. I'll tell you a little bit more about that. So this was a study on, slides got a little messed up, but the point here is that they did opt-out testing within 13 federal qualifying health centers in Florida, New Mexico, and Puerto Rico, and they found that to be an effective way of picking up new and out of care HIV positive individuals that presumably would have been missed otherwise. There was a study in Kenya, where they trained mototaxi drivers to offer quick HIV testing, and were able to pick up new HIV infections, and then also to test positive, to test partners. And then in Memphis, there was a study looking at providing HIV and syphilis tests in vending machines. And likewise, we're able to pick up some new HIV positives and then link them to care. Second theme, lots of interesting work on biomarkers here, and the capacity to conduct these at home or elsewhere without having to travel for the participants. So including one looking at drug levels with finger stick for men, and then also looking at viral load, and then looking at viral load testing using the TASO device that people can do their own blood draws through their arm. And Kevin Sassaman presenting on the urine urine drug level test to pick up people who are poorly adherent, and then to use that to guide interventions. So, and then real quick too, a number of studies looking at pharmacy opportunities and developments and the use of pharmacies. There was a cluster randomized controlled trial in Kenya of 3 different approaches to how to staff and how to resource pharmacies for PrEP implementation. And all the ones that they tested out, don't have time to give the details. All of them outperformed standard of care procedures at other pharmacies. And our own MJ Heise, is that how you say her name? I have her name, MJ, that works with Matt and others, had done some analysis of California data of changes in the number of pharmacists who are prescribing PrEP following the California Bill 159. And there were increases there, but still fewer than 1% of PrEP prescriptions are actually provided by pharmacists. So lots of room to grow there. And that's my super fast version of my slides. So, okay.
That was a lot, and you did that very graciously.
Oh,
Thank you. I think
we're at time, but what do we
yeah,
think?
I mean, I think we have time for one question.
Okay, none on
What I
the,
meant to say is about OPVs, that they don't do enough.
They're not vaccinated.
men, they
Yeah,
just
but that's-
vaccine
But
women,
that's, but those data are like.
cervical cancer.
These are adults that are,
Yeah.
that were aged out of HPV vaccination. So
Yeah.
you're not looking at vaccination effects there.
Yeah,
You're looking at behavioral risk factors. But you're right.
We gave the Favres the entire world for about a decade. As far as I know, there was no reduction. There were randomized clinical trials of Favres versus basically the PIs. There were no impacts on all the comorbidities.
None of the clinical trials were powered to look at clinical events, particularly cancer, infection-related cancers, or TB. I think are the things that I think were. What's that?
Were there any trends in the data?
Not that we're reporting. So I don't, I just, I'm just wondering, whether there's more to this than meets the eye. And there are new drugs in development now that have enhanced attack activity. So
They're in their phase 2, right?
yes.
okay, people want the recording. Otherwise, I think they liked it. And thank you so much, Peter and Mallory, for presenting. Thank you, everyone. Bye.